joining, and thank you so much to our panelists here. This is the second actually in a series of oncology payer webinars that we've done this year. The first one was moderated by our team in the EU, and wanted to have a similar discussion with some of our payers here in the United States, given we're kind of recognizing the differences in terms of the market and the nuances. This is kind of built off of some of the topics that our team has been looking into this year in terms of just ongoing trends in the oncology pricing market access landscape, things like combination therapy, and what some of the strategies might be for manufacturers who are developing products that may be used in combination, and what kind of issues they might have to consider when it comes to pricing, and some of the challenges when it comes to access when their product is in combination with other agents. And we know that that's a very strong focus of clinical development, recognizing how do we optimize what we have already and add to it, and sort of seek the best of both worlds in terms of kind of getting the existing getting incremental benefits. The other topics that we have today there's two. One is we did want to spend a few minutes talking about Keytruda and the eventual loss of exclusivity and potential impact of that for some of the PD-1 and PD-L1 inhibitors that are on the market. We recognizing what a kind of impact they've had to the state treatment landscape across oncology. It'll be definitely something that I imagine is going to be of interest to our payers and certainly to manufacturers who are developing and marketing their products here. The last topic is on a new kind of approach, and not necessarily new in terms of investigational, but I think we're starting to see more and more success in kind of clinical utilization of mRNA vaccines. And certainly the COVID kind of launched, I think, the public awareness of mRNA vaccines with the COVID vaccines. But their utilization in oncology, I think, is something that we're hoping to see, from a clinical standpoint, really kind of kick off. I'm happy to welcome the peers that we have on the line. We have Maria and Ryan. We're hoping to see one more person, but we'll get them on board when they come. Why don't I have the two of you just introduce yourself briefly, tell us a little bit about your role in the organization that you work for. I'll start with Maria.
Sure. Well, it's a pleasure to be part of the panel. I am a physician, medical director. I've been in this role for over 23 years. On the payer side, I've been with multiple plans, both regional as well as national, including a national PBM and IDN, and now with a large regional plan, heavily involved in policy development, formulary management, strategy, and quality initiatives. About 8 million lives, all lines of business. So pleasure to be with the group.
Great. Thanks, Maria. Ryan?
Yeah, thank you again for being here. It's always a great discussion. Ryan Haumschild, I'm Vice President for Pharmacy and over a large integrated delivery network with a regional managed care portion of the work that I do. I'm responsible for P&T committee review, also developing our disease pathways for treatment. And then lastly, the team that does the pharmacoeconomic analysis of new therapies and combination therapies, which is a little relevant to this discussion today, also reports up to me as well. Looking forward to this discussion. Over 1 million covered lives and growing. And so the ongoing area too of oncology and non-oncology specialty medications continues to be at the forefront of the work I do on a daily basis.
Great. Well, thanks for that, Ryan. Maybe starting with the topic of combination, Ryan, I think we wanted to start by just understanding a little bit from your perspective, how do you see the pricing and access kind of challenges when it comes to combination therapies, their impact on your organization, and how you tend to review them. Can you tell us a little bit about that?
Yeah. Well, I'll start off with the simple equation that 1 + 1 does not always equal 2 when we're talking about combination therapies here, in terms of, one of the things that we've been focused on is combination therapies do add synergistic effects. They improve efficacy, but the cost can be limiting. And so our willingness to pay threshold is really set by what is the clinical improvement we're going to see with combination therapy. And I think a great example is nivolumab and ipilimumab, right? So we're using CTLA-4 agents plus PD-L1s. We're using that in melanoma and renal cell carcinoma, but the cost continues to rise. And now we're seeing quadruplet therapies and multiple myeloma with CD38s. And so it's a nonstop process, but I think we're recognizing there's got to be a willingness to pay threshold that we're willing to cover. And I think with the Inflation Reduction Act and some of the ongoing competition where subsequent lines are all combination therapy, we have to establish a willingness to pay threshold. And so that's some of the work that we're doing, is quantifying what do we truly believe the incremental efficacy would justify what type of price increase, and really creating our value analysis based on that. We are still covering majority to NCCN, but we've started now looking at 2Bs as not always being a guarantee. And so I feel like as we have more constraints, we are going to be more, I think, I would say, intentional about quantifying the improved efficacy and what we think that value increase is worth, and then working with manufacturers, not just saying, oh, this drug is a value of this and this drug's a value of this, so we're going to take the net price. I don't think that's always how it's going to work moving forward.
Understand, yeah. Wanted to ask Maria, from your perspective, what risks do you foresee if the combination pricing problem, remains unresolved?
Yeah, well, I think Ryan teed it up beautifully. It is affordability, right? It's the impact on premiums, but also as we look to, IRA, it's the impact on budgets, and also again back to value, right? What is the value of a combination, especially if we're looking to doublets, triplets, and beyond, and perhaps also becoming a little smarter about looking at the data and who's deriving true clinical benefit, in terms of response, durability. How long do you use the combination for? Are we going to use it sparingly, perhaps, pre-adjuvant or neoadjuvant, but versus, post-surgery, right? So by indication. So, and also, again, personalized medicine, I think, may have some impact in terms of how we think about where's the benefit the greatest to be able to get back to hopefully innovation, but also affordability. So I completely agree. I think, the challenges are, increase, spend and trend, and oncology being sort of number one in terms of concern for that. So, we're on the brink, I think, of incredible innovation, but how can we afford it? Unless, again, we can figure out, and even on the sequencing side, who should get what should that sequencing look like? Somebody didn't benefit from certain, line of therapy. Is it worth keeping that backbone? And maybe, again, going back to personalized medicine, biomarkers, and maybe AI can even play a role over time. And as we look at, big data sets to really figure out and influence evidence-based care in terms of who, where is it worth it? And perhaps where the value just isn't there.
Yeah. Ryan, I know you mentioned that, multiple myeloma being one case example of a therapeutic area where, that impact is really being felt. Are there other, when you kind of think about combination therapies, are there particular, is it kind of indications that come to mind? Is it classes of products that, are going to be maybe more of a focus when it comes to thinking about how to price and what the threshold, of willingness to pay is for from a price standpoint?
Yeah, it is indications. I mean, I think about the enhanced oncology model that our providers are participating in. A lot of payers are joining in there. So myeloma is a part of that. I think about bladder, where we have enfortumab vedotin plus a pembrolizumab. So those PD-L1s now being added on to almost all these innovative treatments, even in breast and HER2 low, studies being looked at, PD-L1s being added on to antibody drug conjugates for ultra low. So in triple negative. So I think, to answer your question, Jim, there's certain therapeutic areas where there's great innovation. And so I think about that. Multiple myeloma, they're looking now at not just bispecifics, but bispecifics in combination with other novel oral therapies. And so that's a disease state that's expensive. And then lastly, with the PD-L1s, agnostic of PD-L1 testing, we're seeing there becoming more support for the addition. And it's easy just to add on a PD-L1, but I think the cost is a key consideration. And so when we think about biosimilars, will that be something that's a low enough threshold that the additive therapeutic benefit is worth it? But it's going to have to be a biosimilar. So I think those are the key areas that jump out to me. And to your point, even the orals and IVs, right? We're seeing that as well with TKIs being added on to PD-L1s and bladder cancer and renal cell carcinoma. And, you know, the difference too I see here is if it's one manufacturer, then maybe we can influence that total net price through a rebate structure. But what happens when one is an external manufacturer and one is, you know, a different manufacturer? And how do we have price consolidation and control when they each have different drivers? And I think that makes it even more complex. And I think then how do we react to it is by focusing and establishing what we think is the net price to pay for coverage. And if not, do we get more restrictive criteria? How do we manage through it?
Got it. Yep. Maria, any thoughts on kind of the approach and areas that you see kind of being a focus here?
Well, I think the approach, and I think Ryan, you know, teed up some of the issues we have, but the approach tends to be looking at data, also starting with NCCN, but you know what's recommended by NCCN, and if there's multiple options, multiple combinations. Again, I think multiple myeloma is absolutely a focus, not because it's our biggest cancer, but also, but because of the many options we have with multiple combinations. And so even as we now have multiple CAR Ts and BCMAs coming and in combination, you know, combinations of what, right? Because that will certainly have perhaps, you know, associated different costs, but looking at the clinical data and can this be sorted out, right, through sort of looking at cost versus value, or maybe a personalized approach. But I think all areas, I mean, even in smaller disease states like, you know, CLL, for example, right, we're already seeing some competitive market that may be driving, again, preference for some agents or within a class over others, you know, driven again by price, safety, you know, and looking at efficacy as well. So even smaller disease states, I think, again, where there's some opportunity to improve outcomes, reduce costs, and again, with the also focus on what's coming, IRA, there's some oncology drugs on the, you know, Part D side that, you know, are targets. And with that, I think that will certainly impact the class and even within the class, branded agents in terms of sort of setting, resetting what fair market price will look like.
Got it. Yep. Yep. So definitely heard that, you know, there's definitely some tumors and malignancies that are, you know, are already kind of considered big budget impact kind of scenarios for the plans. But also, you know, that there are, you know, times where it may not be very big, you know, it may not be that many patients in terms of prevalence and incidence, but we have a number of options, you know, within a class, and you know, those may be opportunities for plans to start to look at some options to get, you know, kind of you know, discounted or rebates or contracting to kind of bring down the net price. Is that right?
Yes, yes. And I think, you know, Ryan also teed up biosimilars, right? To the extent that the checkpoint inhibitors are being used in combination, more and more really for, you know, across many indications. And they're in the top 10 in terms of, you know, spend and trend, and that's only going to continue to grow. To see pricing relief, right, with biosimilars, or maybe even pricing competition that starts to occur, that hopefully in the end lowers the cost of combinations to some degree. But that's the, you know, that's the great hope is, you know, cost relief, and where are some of the opportunities to be able to achieve that.
Yeah. Great. Well, I know we've been talking a little bit about this already and wanted to kind of turn to our next topic of conversation, which is the Keytruda potential, you know, loss of exclusivity. And, you know, wanted to start by asking, how do you anticipate the loss of exclusivity of Keytruda and some of the other PD-1s like Opdivo affecting the oncology market, how your organization approaches it? You know, to what extent do you see the LOE for Keytruda being similar or different from some of the other ones that we've seen in oncology, like Herceptin or Avastin or Rituxan? To what extent is it going to be looking like that? Is it going to look, you know, to what extent it's going to be similar or different from other big brands like Humira that we've seen, you know, in other therapeutic areas? And maybe I'll start with Ryan.
Yeah. Yeah, with an oncology, it is a little bit different than a non-oncology indications like Humira. However, I think biosimilars are going to have a huge impact. I think when we look at pembrolizumab, I think it's up to 800 indications. I'm being facetious, but there's a lot. And I feel like there's even more clinical trials being studied. I see some of the manufacturers pivoting to try to create, they're kind of mixing their PD-L1s with hyaluronidase and coming up with a sub-Q formulation to extend patent life. Okay strategy, but I'm not sure that's going to be the majority of the way that we move forward. I do think biosimilars are going to make a huge impact, Jim. There's a lot of opportunity where there's overlapping indications with pembrolizumab. And as we've seen, when we adopt biosimilars, we're able to reduce the cost of care. We have to be thoughtful as payers. If you look at Humira, those that have kept Humira on as formulary, even with biosimilars preferred, they've only reduced cost savings by about 30%, where those that have eliminated Humira from their formulary have increased cost savings up to 70%. So I think that's going to be, how do you take a hard line, especially in oncology? I do think it'll be a phased-in approach where we'll create the opportunities. The rebating will initially be smaller, and then as more biosimilars enter the market, we'll see an increase. And I think we'll get to a point like we have with Avastin, right? Where bevacizumab, Avastin had the orphan indication for ovarian, but the biosimilar did not. But we're seeing biosimilar use and approval of use from both provider and payer for the orphan indication, and that really hasn't been a barrier. So my answer to you is I see adoption in the future, especially as the IRA is coming, out-of-pocket expenses for patients will be changing. The price negotiation from CMS will increase. It'll probably be more of a slower rollout just because it is oncology and there is specific data for Pembro than there is Nivo. But wherever we have overlapping indications, we might see more preferencing moving forward, which I think will be innovation itself for a lot of our payer colleagues. So that's my kind of initial approach of how I see the market changing and the dynamics. So happy to answer any other questions as needed.
Yeah. No, that was great. And I guess for me, Maria, one question we had was, with the LOE for Keytruda, how do you anticipate its role as a price comparator in kind of reviewing products and the cost and the price and the achievable kind of willingness to pay change as you start to see biosimilars? Do you see how does that going to look, maybe sort of in the context of situations where Keytruda is one of the therapies? How's that going to look if Keytruda is one part of the regimen, maybe that a novel therapy is entering the market in combination with?
Yeah, I think we're going to try to leverage, if Keytruda is an IO, if there's several biosimilars, that's the great hope, right? As prices drop, that the backbone, it doesn't have to be the brand, right? That an IO is frankly an IO. And so that especially with a biosimilar, that the outcome should be similar if we can, extract savings with a backbone checkpoint inhibitor that is similar. Particularly with the loss of exclusivity of Keytruda, if there's once, we have 2, 3 biosimilars of the same product, usually that's where we see, significant potential savings. And so with that, then to be able to essentially, with a combination, to go with a lower cost biosimilar option that hopefully generates some savings and frees up savings, hopefully for the combination, so that it's not as significant on your budget. So essentially, I think biosimilars will put increasing pressure on the branded agents to either, we haven't seen usually much contracting on the medical side, but as Ryan mentioned, I think that'll add substantial pressure and some opportunity again to manage the combination with a lower cost backbone substitute. So I think it'll just reset the price. And hopefully it's a good thing because, again, these agents are in the top 10. They are being used more and more in combination as the backbone. So it's a way to generate, hopefully, ensure the outcomes, but also generate some savings. So completely agree. We have to be evidence-based, but also cost-conscious.
One question that comes to mind is when you kind of what's the benchmark for interchangeability or substitutability with the biosimilar is, to what extent is it different from generics? To what extent is it all different when we're talking about oncology? Rob, I think Ryan, you were saying that that it doesn't necessarily require, an FDA approval in some of the indications where a brand has one, but the biosimilar may not. What's been the experience from the plan standpoint, and what's kind of been the kind of your experience in talking to providers and their willingness to use a biosimilar, where there may not be kind of direct data in a particular indication?
Yeah, and the assumption is they never will, because if you have to run the trials all over again, you're gonna, what's the point? But I think we've done a lot of education. A lot of our providers are, becoming more and more comfortable understanding that this is hopefully about, being cost conscious. And, I don't think they really believe they're compromising outcomes. Also, I think it's important to understand that, with a biosimilar, it's similar. And even amongst the branded originator, no batch is created equal. So I think there's a, comfort level that's starting to occur, not just amongst oncologists, but other disciplines, IBD and RA, et cetera. I think, this isn't, we've done a lot of education. We have biosimilars on the market. As Ryan mentioned, we already have Avastin, Rituxan, Herceptin, the G-CSFs. I think, when we talked about the G-CSFs way back when, the conversation was more about the financial incentives that drove kind of the business model rather than any clinical differentiation. So my point is that I think there's already an established, comfort level with the use of biosimilars and that they're similar. I think, the medical side, we have to make sure the alignment of incentives is there more than anything else. And I think it's going to be the alignment of incentives is going to drive demand.
Okay. Yeah. Ryan, wanted to maybe have a follow-up question about the subcutaneous formulation of PD-1s. Certainly wouldn't be the first time we've seen a branded innovator product, kind of introduce new formulations, different routes of administration as they, get close to LOE and try to, kind of differentiate. How do you envision, managing the use of the sub-Q relative to the IV? Is there, would there be a scenario that you could see where in fact you would in fact prefer or restrict access to the sub-Q or prefer the IV formulation over the sub-Q?
It's a
IV
great question.
biosimilar in this case.
Yeah, because I think it's two scenarios, right? So if there's no biosimilar, and I'll use daratumumab and daratumumab Faspro, and you have almost parity in pricing, that as a payer, you provide access to both. I think the difference, and we've seen this, right, is we've seen trastuzumab with hyaluronidase, rituximab with hyaluronidase already in oncology, and we've seen preferences from us as payers for the IV formulation based on cost alone, where you have the biosimilars in trastuzumab, the biosimilars in rituximab, and it's driving a better net price. Now, if the branded manufacturer can get the rebating of the subcutaneous formulation down for the plan, then you create parity access. But if not, then the cost effectiveness is going to drive you towards the IV product. And then there are some situations, right? If a patient has transportation vulnerability, they're not able to handle the IV formulation, then there can be exceptions to the policy. But I think, again, you want to drive cost-effective care. And we've seen that already with trastuzumab, rituximab, and other subcutaneous formulations where biosimilars are already available.
Great. Wanted to transition to our last topic today. So wanted to get some thoughts around mRNA vaccines. And, do you, wanted to ask, do you anticipate any challenges, any unique opportunities for mRNA therapies that are kind of unique compared to, kind of what we've seen today in terms of kind of the treatment and available options for oncology therapies? And maybe I start with Maria. Like, what are your thoughts around kind of the potential for mRNA vaccines, and to what extent do you kind of see some different pricing and access implications for them, or kind of thinking about kind of how you would review those products relative to available therapies?
Sure. I mean, there's a growing category of in the oncology space for therapeutic vaccines, whether it's glioblastoma or even common cancers like non-small cell lung and head and neck, et cetera, triple negative, right? So a growing list in the pipeline that's being explored. Having said that, you know, mRNA vaccines will have, I think, a very different price potential when you move over to oncology versus where, you know, historically they've been. But, you know, again, back to hopefully, you know, they're fast production. They tend to be well tolerated. We'll know more about their humoral and cell-mediated immunity. I think a lot of where they're being studied is, again, combination with checkpoint inhibitors. So we'll see what that ultimately looks like. But, you know, they are in the pipeline. And, you know, again, it will be interesting to see what value they're going to bring in terms of response and hopefully survival and minimizing toxicity. But there's a lot of, you know, promise, I think, in their use and hopefully, you know, come to market for multiple indications in oncology with good value.
Okay, great. Ryan, wanted to give you maybe the last bit here. Thoughts from your standpoint on mRNAs and vaccines and their potential use in oncology, their, you know, kind of the pricing and access kind of thresholds that you'd be looking for them. Is it pretty similar to existing what we've done to date, or are there things that you're looking out for that might be somewhat unique?
Yeah, you know, great questions. And, you know, mRNA vaccines actually emerged from oncology, right? So that's really where the studies happened. And that technology was adapted for the COVID-19 pandemic in rescue there. So I feel like there's a lot of research there with mRNA vaccines. As my colleague Maria eloquently put it, it allows you to create almost an infrastructure where you can tag different antigens within that infrastructure of the vaccine and make updates pretty quickly. I do see mRNA playing a huge role in oncology in the future. I know there's a lot of vaccines right now that are being studied that made it through phase 2 data, and I think can make a really big impact. When I think about it through a payer lens, right, managed care executive lens, I do think about what's the time to return on that investment for that mRNA vaccine. Is it going to improve my total cost of care? Is it going to improve efficacy such as PFS, OS, or durability of response over time? I think that's still remaining to be seen. And I think the way we'll price them is how much value I get within 3 years of making that coverage decision for my plan, because I might have a 4-year turnover. What's the 5-year benefit? And is it being used in combination or not? And do I benchmark it according to previous mRNAs made for more viral treatments or not? And I think those are some of the trade-offs that I'm looking at that'll come into my cost effectiveness. But I'm definitely aware, I think they'll be an important part of disease and cancer treatment in the future. And I think the price will just depend on what's that return on investment per se with the economic parameters.
Great. Well, Ryan, realize we're going to be out of time here, but thank you so much for taking, you know, the time out of your day to talk to us. I think this has been really interesting and insightful discussion, something that I think we'd love to be able to continue in the future. Any final thoughts or comments before we wrap up?
Yeah, no, thank you for the opportunity. I think this is definitely a worthwhile discussion to pursue. You know, again, to sum it up, we're on the brink of, I think, incredible innovation in oncology. Also with personalized medicine that hopefully will strategize and stratify, you know, what works best and for whom. That really offers not just innovation, but you know, value in terms of improving survival, response, and reducing toxicity. So thank you for the opportunity. It's been a pleasure to work with Ryan.
No, thanks, Maria. Great. Well, Ryan, Maria, thanks again. Really appreciate it. And, you know, thanks for the team here at CRA who helped to put this together. Megan, Austin, Aaron, and the folks on the behind the scenes here. Really appreciate all the efforts you guys put in. So thanks, everybody. I hope everybody has a great day.
Thank you.
Yeah, thank you all for a great discussion.
Take care.